Phone system doesn't work either.
I called back in on the phone and now it's working, but it wasn't for the first call, so I hung up and called back in for the backup number. Oh, let me see. Make sure that's muted. Mm-mm-mm-mm. Oh man, too many people on. Let's see. Set. Okay.
Is the phone in now?
Yes, we can hear you, Mr. Davis, but you have another device nearby that's picking up an echo.
Okay, good. That wasn't me.
Michelle, are you all set?
Yes, I am.
Okay, great. We can go on the record.
Okay, great. We are now on the record. The time is 10:08 a.m.
Great. I'll call to order the Green Mountain Care Board's hearing of September 13th, 2024. We have hospital budget enforcement deliberations and potential votes noticed, hospital budget review for a limited number of hospital fiscal year 25 budgets for deliberations and potential vote, and a review, deliberations, and potential vote for the standard budget conditions. I'll turn it to Mark Hengsler, our counsel, to provide an overview of the enforcement process.
Hey, good morning, everybody. Happy Friday. I'm going to go ahead and pull up some slides right now. It's a beautiful morning and a beautiful PowerPoint. So what we are going to start today with is an overview of the budget adjustment application process and an overview of the enforcement process. And honestly, I want to provide this overview not for the board, because the board knows this, but I want to provide it for the public because we haven't really talked about the process that we're using for at least a week now. Today, we're here discussing potential enforcement motions and motions to decide on applications for adjustment from a few hospitals. And it seemed prudent to back up and do a refresher on what this process is and how the board makes determinations under this process. So with that, I just want to start with a little bit of a 101 on the statute, just to separate out two concepts, because we're going to be talking about both, and I think it's important to just define both and couch what each of these are. So to start, 18 VSA 9456 is the board's hospital budget review statute. And there are two parts of this statute that I want to point to. One part is about benchmarks or benchmarking, and the other part is about budget orders. So to start, I'm going to just point to this first bullet point, which is the benchmarking bullet point. And I'll say that in the statute, when the board is reviewing a hospital's budget, it's looking at a lot of factors to analyze whether to approve or modify or adjust a budget. And there's a subsection of the statute that allows the board to establish a process to define on an annual basis criteria for hospitals to meet, which we call benchmarks. And the board under statute may waive some of the criteria that it's required to review if benchmarks that it has established have been met. So that's what benchmarks are in the statute. To say it, and I'll say I'm going to try to describe some of this stuff in a plain languagey way and not a legally way. And I'll just couch that by saying that the advantage of doing so is that I hopefully sound a little bit more like a human being when I'm talking to you. But the downside of doing so is that I run the risk of potentially oversimplifying some aspects of the law. So just to say, I'm going to try to say this in a plain language way, but I want to just caution that I'm doing my best to say this clearly without removing things. Okay, with that, so what are these benchmarks? These benchmarks are a tool. They're a tool that the board can use to help it evaluate its analysis of budgets in a given year. That's what benchmarks are. Separately, in the budget order or the budget hospital budget statute, there is a budget order subsection that states that annually the board shall establish a budget for each hospital on or before September 15th. Here we are today, September 13th. That's what we're doing in part today, followed by a written decision by October 1st. Each hospital shall operate within the budget established under this section, meaning that the board issues an order. That order explains all of the conditions a hospital must follow. It explains the legal rationale for the board's decision, and the hospital needs to follow the order. So we have benchmarks, a tool used in the budget process, and an order which the hospital must follow. We're talking about enforcement, so I'm going to go back in time to guidance that was set in 2022 for fiscal year 23. And I wasn't here in 2022 or 2023, but my understanding is that at this time, when the board was setting guidance or benchmarks, we use these terms interchangeably. When the board was setting benchmarks for fiscal year 23, it chose to do something unique and set a 2-year aggregate benchmark of 8.6% for fiscal year 23 and fiscal year 24. My understanding is this was an attempt to provide some latitude for budgeting, given all of the uncertainty in the industry. And this guidance, again, this benchmark guidance was about setting a benchmark for hospitals. In other words, setting up criteria that would help the board evaluate how to weigh information and make decisions as to each individual hospital's budget for fiscal year 23. So this was the guidance. We call this the fiscal year 23 guidance. So the board went through its process for fiscal year 23. It made decisions called orders for fiscal year 23, and that resulted in an order for each hospital. And each hospital ended up with a order with many conditions. The first condition, condition A in each order, was an order concerning the net patient revenue. I'm going to say cap, the total net patient revenue that a hospital could bring in for fiscal year 23. And I'm pulling up these 3 hospitals in particular because these are the 3 hospitals that we're looking at today for potential enforcement. And I just want to identify, this is language from each of the fiscal year 23 budget orders. And what you'll see in each condition A is a introductory statement as to how, what percentage was used and from where, from applied to what, applied to fiscal year 22 budget in order to get to the cap. And then what you see is the total cap, which is listed as a dollar figure. So for Rutland, we see the 313 million for fiscal year 23. For UVM, we see the 1.6 billion for fiscal year 23. And for Porter, we see the 104 million. And those were the ordered net patient revenue amounts by which the hospital cannot go past caps. So those are the orders. I'm going to go back to the statute for a minute. The statute anticipates the possibility that because budgets are budgets, things might change mid-year. And so the statute lays out a method by which a hospital may apply for a adjustment to its budget, and the analysis with which the board must determine whether it approves or chooses to deny the application for adjustment. We've seen this process play out recently. For FY24, I believe Copley came in mid-year and requested an adjustment to its commercial rate. I believe there was a prior year where another hospital, it might have been Rutland, came in and requested a downward adjustment. But we've had mid-year requests from hospital in the past, and what the board does is it looks at the application and it determines if there's a showing of need based on exceptional or unforeseen circumstances, meaning something has happened and the budget cannot be adhered to as ordered. And if the board makes that finding, it at its discretion may choose to adjust the budget in some way. So that's the adjustment subsection of the statute. In the statute, along with this anticipated understanding that hospitals may need to come in for adjustments, is an understanding that the board may need to do something if a hospital is not able to comply with its budget order. And there are a few things the board can do. I'm just pulling up language for what's relevant today, but what I will just say is that in the statute, there is a power for the board to go into civil court and get a court order requiring that the hospital not violate or deviate from its budget order. There's an ability for the board to do something that, to my knowledge, we've never had to do, and I certainly hope we don't ever need to, which is impose an administrative penalty on a hospital for willfully violating a budget order. That is not something we're talking about today. We're not talking about administrative penalties today. That's not what we're doing. And then finally, there is a more, I would say, more kind of flexible option available to the board, which is in this final bullet point that I have here. And that says that if a hospital violates or deviates from, it says that what the statute says, if a hospital violates a provision of the section, but as I pointed earlier, one of those provisions is that the hospital shall comply with the board budget order. So if a hospital deviates from a board budget order, what the board can do is take such corrective measures as are necessary to remediate the violation or deviation and to carry out the purposes of this subchapter. So in other words, the board can take a corrective measure to attempt to remedy and kind of, you could think about as get back on track when a hospital deviates from a budget order condition. The board has a practice of looking at potential enforcement year end. So that's how we deal with enforcement. So all that said, again, we're here today about enforcement. FY23 actuals came in and the board found that Rutland, UVM, and Porter's net patient revenue caps, those highlighted dollar figures in condition A that I showed earlier, had been exceeded. And when the board identified that in its enforcement review, it sent a letter to the hospitals, sent a notice. And here's excerpted language from the notice to UVM on the top concerning the medical UVM, MC, and Porter, and the notice to Rutland on the bottom. And what you'll see here is that the yellow highlighted figures for UVM, the 1.6 billion, for Porter, the 104 million, correspond to condition A of the budget orders for fiscal year 23. The orange figures that are listed are what the actuals were. So you'll see that the number for UVM, the actual was over, the number for Porter was over, and then you'll see a percent. So for UVM, there was an overage in net patient revenue by 4.8%. For Porter, there was an overage by 10.5%. And then for Rutland, you'll see that there was an overage by about 3.5%. So that's what the notices explained. And notice the hospitals as to information the board needed to conduct a review, explained the proposed plan for hearing, et cetera. The response that the board got from these 3 hospitals was a detailed submission of everything the board requested so that the board could evaluate. Sincerely appreciated for the amount of time and energy that went into the process of getting that material to the board from each of these hospitals. I just want to say that. And what the board also received from these 3 hospitals was a request to retroactively adjust the FY23 budgets such that the net patient revenue cap would be increased and there would be no overage. So what the board got from the hospitals was this application to retroactively adjust for fiscal year 23, which meant that in this process, the board was looking both at the hospital's application for adjustment retroactively and the board's intended procedure of moving through enforcement determinations to decide if enforcement was warranted in any of these cases. So I just want to kind of couch that so that we have a little bit of the history there, and in case there's any confusion, I just wanted to clear that up. And with that, the next thing I want us to look at is, okay, so the board is looking at these applications to retroactively adjust submitted by hospitals. The board is looking at its own process of determining whether to enforce these overages. What factors is the board weighing when it's making these determinations? And the answer to that question is in the board's rules. So Rule 3.401 applies the considerations that the board must take up when it's weighing both either or both an application to adjust or a decision to enforce. And what the board is looking at are these items that are here. So when it's determining if there's been a substantial deviation from the budget, it's looking at the variability of a hospital's actual revenues, taking into account the resources of payers and the methods of payment used by the payers. Resources of payers, I'll just say, you can think about a simple non-legal way of saying that. Where is the money? Is there money to pay for the overage? Where is the money to pay for the overage? What are the resources of the payers? I think we heard some public comment from the HCA that was asking a question to that effect, and I understand that question to exist in this first consideration. The second consideration is the hospital's ability to limit services to meet its budget, consistent with its obligations to provide appropriate care. So there's a weighing that the board must do here, which is a little bit which I would say is not an easy job, right? Trying to figure out what services or expenses could be limited and can appropriate care still be provided, right? That's a factor the board is really trying to weigh here and has a lot of data to try to do that. 3, the financial position of the hospital in relation to other hospitals and the healthcare system. 4, the hospital's performance under budgets in the past and some projections, and then any other considerations deemed appropriate. And that includes instances in which a hospital might have less than full control over the expenditures limited by the budget. So those are some of the considerations that the board is looking at. The process of trying to make a determination is multifaceted. Similarly, the board is left a lot of options in rule to try to remedy a deviation from a budget or to try to respond to an application for adjustment from a hospital. And the rule does its best to really account for some different courses of action the board might take in order to respond to either an application for adjustment or to enforce a budget order to take the corrective measure that the board deems necessary. So you'll see some examples in here of actions that the board may take, and you'll see that some of them swing in different directions. So some of these might swing more toward the general concept of letting the overage ride in this circumstance, and some swing more to the concept of finding a way to adjust the hospital's budget in accordance, or adjust something in accordance to kind of true up the intent of the budget order. And I'll just read some of these so we have them fresh. The board may adjust a budget by 1, changing hospital rates or prices by the amount of net revenues exceeding the budgeted net revenues. 2, changing the net revenue and/or expenditure levels of future budgets. 3, allowing hospital rates to be increased for a hospital with a deficit caused by revenues that were less than projected, but whose actual expenditures were within the budget limits. 4, allowing a hospital to retain surplus funds if the surplus was achieved while the hospital stayed within its established budget. 5, allowing a hospital to retain a percentage of surplus generated primarily by volume in excess of that projected for a particular year. Or 6, any other circumstance the board deems appropriate. And with that last item, item 6, I'll turn to one final document that's relevant to this analysis, and that's the board's policy on hospital budget enforcement. So since 2021, the board has had this particular policy on budget enforcement. I think it was Member Lunge who identified at a prior meeting. The board has had other enforcement policies in prior years. I won't pull up those, but this policy, which has been incorporated in guidance and was incorporated in guidance in 2023 for the hospitals, is a policy about what the board does when a hospital exceeds its net patient revenue cap. The policy was implemented, it states, because some hospitals were exceeding these caps, which was resulting in unanticipated commercial costs. I'm not a policy person. I want to be careful about stepping out of my lane, but what I think I've heard in these deliberations and in hearings is that when we're talking about a net patient revenue cap, we're talking about the board trying to limit the increase in commercial premium growth and commercial costs due to the hospital system. And if I'm hearing everybody correctly, it sounds like what we're also trying to do with the net patient revenue cap is encouraging, where appropriate, hospitals to shift utilization that does not or should not be happening in the hospital setting to more appropriate community care settings. And I'm sure there are other elements to that, but just to kind of give a very general kind of public overview of that concept. The policy states that deviation greater than 1% from an NPR cap, from a net patient revenue cap, may cause the board to take enforcement action under the rule that I just pointed to. You'll remember from those notices that I showed you that these net patient revenue deviations for fiscal year 23 were more than the 1%. I'll actually just click back and remind you that for UVM, it was 4.8, for Porter, it was 10.5, and for Rutland, it was 3.2. And finally, the policy lays out some specific actions the board may consider in response to a net patient revenue overage. And there's a list, but 2 of those I wanted to point to is that the board may decide to reduce the hospital's rates, and or the board may decide to adjust a hospital's budget in 1 or more subsequent years. And I pointed those because those to me seemed relevant to today's discussions. So with that, that's just the overview that I wanted to give on enforcement before we move into motions. But I'll turn it back to you, Chair Foster, because I understand we may have a request as well for an executive session.
Okay. Is there a request for an executive session?
Yes, I would like to make a request for an executive session to discuss to get some legal advice on the fiscal year 25 hospital budget. I'm sorry, the fiscal year 23 budget enforcement objections and process. So I'll go ahead and make those motions. unless Mike would like, or Mark, you would like to review the mechanics and the rules of the road for executive sessions before I do that.
Well, let me just ask, Mike, is that something that you'd like to do?
No, I think covered it last meeting, and so go ahead.
Great, thank you. I move that we find that premature general public knowledge of confidential attorney-to-client communications regarding the objections raised by hospitals with respect to the fiscal year budget enforcement recommendations and process, as well as the material Mark has reviewed, would clearly place the board at a substantial disadvantage in any dispute that may arise out of these processes.
Second. All in favor, say aye.
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 I also move then that we go into executive session to consider confidential attorney-client communications of the items that we just found would provide premature general public knowledge.
Second.
All in favor, say aye.
Aye.
So we will take a break from this meeting to go into executive session. We will invite counsel for the board, and the health systems finance team, Ms. Barrett and Ms. Lajeunesse. And it's always hard to predict how long we will be in executive session, but I will say 45 minutes. So 11:15, and that could extend. We'll notice it if it is extended. Thank you. So we'll take a break and come back.
Okay, we are off the record at 10:32 a.m.
Ms. Barabee and Mr. Hengstler back?
Yes.
Yep.
Shall we can go back on the record?
Hey, we are back on the record. The time is 11:17 a.m.
Mr. Hengstler, were there slides?
I am pulling them up right now. There we go. That should do it. Yeah, looks like it. Okay. So let me jump ahead. And we are now looking at motions for budget adjustment and budget enforcement. And I'm going to start with Porter. So what I'm going to do for each of these is I'm going to present the motion as stated at the board's deliberative session on the 11th. And then I'm going to show a slide with a suggested adjustment to motion language to account for effectively what I understood the intent of each verbal motion to be. I'm not considering these really major changes from what was proposed, just attempts to frame what the board is doing with a little bit more clarity in writing. You know, doing these verbally, it's hard to get in one go. So the motion language from the 11th was a motion that at this time the board not take action on Porter's potential enforcement for its overage in FY23. The suggested motion language that I have here is the same with the addition of an item that was not stated last Wednesday, which was a motion included to deny Porter's application for retroactive adjustment of its FY23 budget. The board again is considering considering that retroactive application, which was submitted with Porter's response to the enforcement notice as described at the beginning of today's deliberative session, and issuing including a determination on this is consistent with what the board has done with the other enforcement motions where it has moved both to what to do for enforcement and moved on what to do for the application for adjustment.
Thank you. And this was my motion originally, so I will make it again and see if there's a second, and then we'll have board discussion. I move that at this time, the board move to deny Porter Medical Center's application for retroactive adjustment of its fiscal year 23 budget and not take action on Porter's potential enforcement for its overage in fiscal year 23.
I'll second.
I will open it up to the board members for discussion.
Sure, I'd like to make a couple comments if I could, Chair. I'm uncomfortable not enforcing our budget order at Porter. The overages that have happened were not unforeseen or exceptional. And in their testimony just last week, they told us their operating costs were mostly fixed, which means that most of their expenses were already contained in their budget and would not vary substantially with either lower or higher utilization. In addition, they're part of a health system where we've seen surprising amounts and potential patterns in the differences between their budget and their year-end actuals. The degree to which these budgets have varied diminishes the credibility of their submissions and the credibility of the budget that's before us. Back to you, Chair.
Thank you. Any other board members have thoughts on the motion?
I have a question on the motion, I think for Mark. and you may have stated this, I was reading something and missed about a sentence of what you said, so it could have been in there. But would this motion make it such that if would it allow us to reconsider budget enforcement at a different time? If, for instance, there was a different view. I think part of why this motion is being made is that there is a FY24 looks currently under budget from so it kind of contextualizes FY23 to some degree. And I'm wondering if this allows us to relook at this later if that FY24 does not appear to be under budget or the context of FY23 changes.
I'll do my best to answer. The original motion language was to move that at this time, the board not take action on Porter's potential enforcement. The suggested language sandwiched in this text in red. If the board were to want to characterize the motion more consistently with the one that was presented on the 11th, I might recommend changing what I actually have suggested here. Instead, the language would be move that the board deny Porter's application for retroactive adjustment and move that at this time the board not take action, just to make as clear as possible in the motion that the board is considering potentially reviewing the matter at a later date. I think that probably isn't totally clear in this language as I've written it, I realize.
I might have some further comments later, but I'll stop for now.
Members Holmes or Lunge?
I'm struggling because I'm not comfortable not enforcing. I'm not comfortable with the enforcement that was last on the table. So, and I also, I guess I'll just leave it at that. So I think at this point, I'm sort of balancing those two possibilities. So I'm open to the suggestion that Dave made to leave the possibility open to reconsidering enforcement after seeing where fiscal year 24 lands. And if I'm voting right this minute, I probably would support this motion, just given my various discomfort with both options.
I would support this motion, given what we know about their days cash on hand, their relatively low prices, the financial support needed for the Helen Porter Nursing Home, which, at a critical time for long-term care, which is very vulnerable, is imperative in this community that Porter operates in, and their projected 24 NPR. I support this motion as it stands.
I think I provided the reasons why I made the motion previously, but it was largely a review of the pertinent factors, and one of them weighing heavily on me on this motion was the financial position of the hospital, considering the relatively low days cash on hand, and the fiscal year 24 projected, which I recognize was only through, I think it was June. But the CEO provided some information that the rest of the year was trending that way, and there's 17 or so days left in fiscal year 24. I understand the difficulty with this, but that was my rationale.
Robin, could I ask you a question?
Please.
Which is, where is there an enforcement range that you would feel was appropriate to apply to Porter at this time?
So I think for me, one of the things I'm struggling with is that is the big swing between 23 and 24. And so I am struggling with determining the exact number that I'm comfortable with, which is why I think between the two options, I would probably, as I said, I would support the motion. What I'm worried about is setting up, or I should say part of what I'm worried about is setting up a fiscal year 25 budget that is just either unattainable because of where they are currently running, or relies too heavily on one price versus, so in looking at the balance between price and volume, trying to balance that out in terms of, I think what we saw during COVID was a heavy reliance on price because of the certainty there. No one knew really what was happening with volumes. And so, I think we have to get back to a more balanced approach there. I understand why a hospital might choose to come in with reliance on price because it is more certain, but as I think has been a theme of this whole budget season, commercial ratepayers are tapped out. So no, I guess the straight answer is no. I don't have a specific number in mind. And I didn't feel like I could necessarily come up with that without, substantial more discussion, which didn't seem feasible. Sorry, Dave, I don't know if any of that was helpful, but that's where I'm at.
I think it's helpful. I think that, I don't look at Porter as a low-priced hospital. I think the data shows in 22, at least as far as RAND is concerned, is they are basically right at the mean, but then had a pretty big rate increase for FY23, which is the year that we're looking at. And it doesn't seem a surprise to me that the hospitals that are being looked at for enforcement are all the hospitals that had big rate increases in 23. So, and I think we're talking about prices here, generally speaking. A hospital that has pretty good pricing, average in prior to a big rate increase, any enforcement would be a small portion of that rate increase from 23, especially if we're looking at a partial enforcement, not a full enforcement. Even the full enforcement would not make up for the full rate increase in 23. Probably, actually, I'd have to look at the numbers more carefully, but maybe. So, yep. I guess that's what I have to say. Tom, I guess curious if Tom, if you had a number.
I do have a number. We haven't talked about it yet, but it's 67%. That's what they've told us was fixed expenses with their budgeting. That means that the increased utilization that they've experienced that drove them over, those expenses were built into the budget already. So I think we're talking about a very minor price reduction for 1 year when this organization has received large increases for multiple years. I get that we're uncomfortable with enforcement, but this is a minor negative step. So if you ask me for my number, it would be 67. If
67% of what, if I might ask?
so, we've been talking 50%, reducing the total amount reducing the total
I
amount.
understand. Yep.
Okay.
Thank you.
Okay.
Sorry.
I'm trying-
Don't mean to
No.
interrupt you, but you were building it off of the staff recommendation. That's just what I wanted to clarify.
Great, thanks for helping me express myself. No, it's good. I was stuck.
I'll suggest that it appears that there's no consensus at this time. And we can certainly come back to this motion and this discussion and give board members more time to think and consider the discussion that we just had. I recognize that I may be in a different position than the majority of the board on this one. So if three of you think that you would like to vote, you can say so. But if you think we should provide a little bit more time for consideration, I can do that as well. Okay.
I'd be happy to move on for now and come back to this.
Okay, it seems like that might be beneficial.
Okay.
I might actually interrupt Mark before we move on, given that there were some additional considerations that were shared. I will open it up to public comment on the discussion. Okay, and we can, of course, take some after if there's a different motion that's proposed, of course. So we'll move on, Mark.
Next, I'm going to turn to the language as proposed and tabled, now off the table for UVM. And again, the difference here between the original staff language and what was proposed at the last deliberative session verbally is in blue. The concept is to move enforcement from FY25 only to FY25 and FY26. And the effect was to change the percent rate reduction for FY25 and FY26. As with the last motion, I have suggested motion language to, again, attempt to clarify a verbal motion that was just made at the last session. It seems, if I'm understanding some of the concerns correctly, it seems that there was concern about using a percentage figure for FY26, as this might lead to some either confusion or disagreement about how to apply that percentage. So what I've done instead here is supplied language, changed language, which is in red, and that language proposes to, you'll notice, keep the same FY25 adjustment to commercial negotiated rate, but instead of using a percentage figure for FY26, use a dollar figure for FY26 applied to FY26 commercial NPR, net patient revenue, to be applied to UVM's approved FY26 commercial rate in this board's future FY26 budget order. So the difference here, this dollar figure ties out, as I understand it from staff here, to the percentage applied at the last session, but this dollar figure is being used instead of a percentage, as applied again to commercial NPR rather than to rate.
And Mark, that's because the percentage of the dollar certain represents can change year to year.
Yeah.
So this would ensure that the UVM second year would be the same in the absolute dollars as opposed to a percentage, which could vary. Okay. I move that we find that UVMMC's performance differed substantially from its fiscal year 23 budget. Move to deny UVMMC's application for retroactive adjustment of its fiscal year 23 budget, and move to enforce this deviation by reducing the fiscal year 25 overall change in charge and commercial negotiated rate increases from 3.4% over current approved levels to 1% under current approved levels, with no commercial rate increase for any payer exceeding that amount, and with a $40,145,078 reduction to UVMMC's fiscal year 26 commercial NPR to be applied to its approved fiscal year 26 commercial rate in this board's fiscal year 26 budget order. Are there any board member I'm sorry, I should take a second first.
Second.
And I'll open it up for board member discussion.
Yeah, this is Tom. I'd like to make a couple comments. I'm uncomfortable with the 2-year horizon. And I'd like to take a little bit of time to explain why. In previous budget cycles, our hospitals consistently referred to their operating expenses as fixed costs and claimed that 65 to 70% of those were fixed, as we were just discussing with Porter. So for example, when hospitals face budget shortfalls and we've suggested reducing expenses to align with their actual budget, their response has been to say that they could not reduce expenses because their costs are fixed. This has been used to justify raising prices for commercial payers, and Vermont hospital prices are now among the highest in the nation. In this budget cycle, we're discussing budget excesses or NPR overages driven by increased utilization. Hospitals have switched their arguments and stated that they should retain all the revenue over budget because that income is needed to cover unplanned costs associated with the utilization. This would be the case if those operating expenses varied with utilization, but they've argued previously that those costs are fixed and do not vary. So to agree with their current arguments requires me to disbelieve their prior statements regarding fixed costs. So are the costs mostly fixed or mostly variable? This is an important question because it can't be both. Most Vermonters pay for healthcare through taxes, insurance premiums, deductibles, and out-of-pocket expenses. We've read and heard how unaffordable those costs have become. Even when Vermonters are healthy and are not utilizing services, they still must pay higher taxes and premiums, which are driven by increasing hospital prices. Understanding this dynamic is why claiming that we are penalizing hospitals for revenue over budget is incorrect. We attempt to hold hospitals accountable for responsible budgeting, restrain their prices and revenue, and protect Vermonters from choosing between better schools or higher premiums, or having to self-ration their care and avoid seeing the doctor for routine appointments. Over the past few budget cycles, we've observed that some hospitals' actual spending for the fiscal year is close to their initial budget submissions. Other hospitals have shown a substantial difference between their budgeted amounts and their actual spending. Some variance is normal, and normal variance would be expected to be random, with different hospitals and expense categories varying in different amounts each year. Our observations over the past few years, however, have been concerning. There appears to be a trend where the same hospitals have either low or high variance. And in addition, there appears to be a potential pattern with some of the high variance hospitals. This pattern, which seems to be systematic rather than random, suggests that the variance is self-interested and could be used to justify larger price increases than necessary. We need more resources to conduct further investigations and monitor the situation closely to protect Vermonters from these types of budget manipulations, as the amount of money involved is tremendous. We don't, however, need to investigate 2023 further. We know the actual results. 4 hospital revenues were over budget. We're considering 3 today. 2 of the 3 are part of a health system with a recent trend of large variances between their budget and actual results. This system's 2023 budget, their actuals, show tens of millions of dollars due to over budgeting and under budgeting. This is in addition to the over $90 million of revenue that is part of our enforcement discussions. As Mark noted in 18 VSA section 9456 and rule 3.401, enforcement is appropriate when a hospital's revenues exceed our budget orders. The increase in utilization we are discussing has not been unforeseen, nor has it been particularly exceptional. We are not clawing back money or removing any of the revenue they earned previously. We're not setting additional limits on next year's revenue. We're choosing an enforcement policy that reduces next year's prices, and we're discussing single-digit price reductions following multiple years of much higher increases, to the point where we currently have some of the highest prices in the nation. And even with the enforcements we're discussing, our prices will remain exceptionally high compared to national peers. Given their previous statements, the hospital's current arguments regarding greater expenses due to increased utilization are not credible. The hospitals themselves had told us what percentage of their costs are fixed, meaning they don't vary based on utilization. None of the three hospitals have provided credible evidence, in my opinion, justifying their overages or their request to be held harmless. Furthermore, prior collaborative efforts at enforcement have failed. Specifically, the collaborative approach taken with the same hospital system in 2018 has not benefited Vermonters. So for these reasons, the enforcement under discussion today, I believe, should be set at 100% for UVMC and 67% for Rutland and Porter. The 67% figure is based on what hospitals have repeatedly told us about their fixed cost. I believe the enforcement should be in a single year as intended. Some have argued that single year enforcement is too harsh and recommend a more gradual multi-year glide path. But we've never offered a glide path to Vermonters when we've substantially changed their healthcare budgets. In addition, stretching this year's enforcement over more than a year could set a precedent that can be used to add unnecessary complexity to our future budget reviews. This will increase the opportunity for further self-interested budget manipulations and diminish our ability to serve Vermonters' best interests in an affordable, accessible, high-quality health system. Back to you, Chair.
Thank you. Any other board member discussion on the proposed motion?
Can I just clarify something, Mark, real quick before I give my comments? So with this motion language as it is, it states at the end there, and with a 40 million roughly reduction to UVMMC's FY26 commercial NPR to be applied to its approved FY26 commercial rate in this board's FY26 budget orders. So are we reducing with this NPR rate or both for 26?
I am going to do my best to answer. I want to first say that I'm playing mouthpiece in this role because I'm not the math guy. And I hope I play mouthpiece correctly, but if I don't, we do have health systems finance people on the call, and I'm sure one of them will jump on and correct
How about
me.
I direct my question to them first to
That'd be fine.
put you on the hook for that. I don't know. Elena, would you be able
Yeah, can you
to
say that again?
respond to that? So the way that this amended motion language reads, it discusses both commercial NPR and commercial rate with regards to the FY26 the application of the FY26 portion of this enforcement action. Is this $40 million for 26 being applied to a reduction in commercial NPR, a reduction in commercial rate, or both?
It's a reduction in commercial NPR due to rate. So we would expect the prices to be lower in 26 by this amount. The thing that we don't know yet is the denominator. So that needs to be up, right?
Okay. So it'd be a different percentage, and the 40 million is the numerator to figure out the percentage.
Yes.
Okay. Tom, I appreciate your comments, and I appreciate a chance to speak about this. I am in favor of this enforcement action as a corrective measure to mitigate the deviation in the budget of UVM for FY23. There's a lot of information in the record on this, but I think in short, UVM has long discussed the role of the cost shift in budgeting, and the budget process has been described as projecting growth in costs from prior years and offsetting these costs with revenue from public payers and commercial rates. When there's a shortfall in that, that's made up by commercial rates, and that is commonly described throughout multiple budget submissions. So, in my view, independent of where the excess revenue comes from, the play in that whole system is in the commercial rate increase. And in FY23, UVM was granted a pretty large commercial rate increase of 14.77%. That was just prior to my time on the board, but I followed that and have reviewed it. The way I read the statute and the rule and the policy, and thank you so much, Mark, for the really clear introduction to that, is the board has multiple options of which to think about this. And one would be reducing commercial NPR, another would be reducing commercial rate, and there's others that you described. I had thrown out the idea of of NPR previously, just reducing NPR. And I think because of this unique time that we're in, where we've had low utilization in Vermont for a long period of time, and then COVID exacerbating that with a recent spike in utilization, reducing NPR by this amount would, I think, be potentially problematic for boxing UVM's budget in a way that they would have to reduce access in order to make their budget work. So with regard to rate, you could reduce rates and then allow utilization at a lower price, back to the price times volume equals commercial NPR, or equals NPR, but definitely for commercial. We could reduce the price, and that would actually incentivize the volume. So I don't support a broad NPR reduction, but I do support a commercial rate reduction. And the way I read this is that that would lead to a commercial rate reduction in 26. And part of what I think makes me comfortable with that, with UVM, is through multiple data sources, I feel pretty confident in knowing that UVM's prices are high. Vermont's prices are high, especially for outpatient services, but UVM is one of the outliers in Vermont. And compared to UVM's UVMMC's self-described or agreed upon, or I'm not exactly sure, I can't remember exactly which group of comparisons this is, but I took all of the comparators that were in their budget submission and compared UVM's prices in RAND to their prices. And if UVM had Dartmouth's prices, UVM would be 20% less expensive. If UVM had Albany Medical's prices, it would be 27% less expensive. One of the other hospitals that Vermonters get referred to is Bay State Medical Center. They would be 55% less expensive. Recently, we've talked about Boston Medical Center and BIDMC. Boston Medical Center would be 48% less expensive. BIDMC would be 39% less expensive. And we've discussed the Brigham Women's Hospital in Vermont. That would be 16.5% less expensive. UMass is 27% less expensive. Rhode Island Hospital, 51% less expensive. Every one of the comparator group was less expensive. The closest was Yale at 16.3% less expensive. And the average was 38% less expensive, which if you applied that to UVM's commercial NPR for FY25, that'd be about $385 million less in their submitted budget. So I do think that this modest reduction in their commercial rate through this enforcement corrective measure is totally appropriate, and I think would provide some relief to Vermonters in their commercial prices while still encouraging appropriate utilization. So I actually preferably support a 1-year application of this as opposed to over 2 years for some of the reasons that Member Walsh cited, increasing complexity, one of them, and another just applying relief to Vermonters. So I would be comfortable with modifying this to all of it in 1 year. Thanks.
Thank you. I'll take a chance to respond since you both had different views than I did in terms of the 1 year and 2 year, and I'll explain where I'm coming from for purposes of deliberations. First, it's a statutorily mandated requirement that budget orders are complied with. 18 VSA 9456 says, quote, each hospital shall operate within the budget established. And that's a critical tool to control healthcare costs in the state. It isn't just for UVM, it's for the entire state to provide predictability and assurance that healthcare costs won't rise above a certain level. It impacts how insurers conduct their businesses and operations and sets expectations for policymakers, lawmakers, the public, and businesses as to how much more spending there will be. This is particularly the case with a hospital the size of the University of Vermont Medical Center. Submitted budgets that we receive impact our decisions, and in doing so, we consider utilization, expenses, and government payers in deciding how much commercial price increase we should put on our really strained commercial market. If government revenue is higher, we likely award less rate. If utilization is higher in that budget, we may award less rate. UVM fiscal year 23 budget submission represented that an over 19% commercial effective rate was necessary, and the board awarded an enormous increase of 14.77. I had been told I'd be appointed as the care board chair the day that news came out, and I watched the news, and I was amazed at the vitriol that came about because of the board's modest 5% reduction to a huge rate increase. And I was struck by the threats and concerns about patient access and reduction and harm that would happen. And now, having done this role for a while, I recognize that it really just reflects the incredible passion that the team at UVM has for its hospital and patients. And that's important. We've seen that passion in this process, and I've actually really appreciated it. But we have to be objective judges. And in fiscal year 23, that rate reduction actually did not lead to reduced services. It did not lead to access problems. It actually did the opposite. In fact, after a 5% reduction, where there was a fairly dark picture painted as to the consequences, UVM was $80 million over its budget. If a hospital is out of compliance during the course of the year, they have an opportunity to work with the Green Mountain Care Board. That opportunity has always been there in the policy, the rules, and the regs. They can ask for an amendment. We can work together and collaborate so that there's some shared understanding of what should happen, and so that ratepayers don't have to pay more than necessary. Unfortunately, in this context, that didn't happen, and I will note that I expect it to happen in the future. We would prefer to work with the hospital when it knows it's going over, as opposed to being in this position after the fact that, frankly, I think none of us really enjoy at UVM, Rutland, Porter, or here at the board. With that, there are very clear factors, given this is the situation we're in, that we must review and consider in deciding what is the correct course of action. First, the variability of a hospital's actual revenues taking into account the resources of payers and the methods of payment used by the payers. Hospital actual revenues were significantly above budget, and as shown in projected fiscal year 24, they are again. Considering resources of payers indicates there's really no ability for payers to pay for this. In fact, there was really no credible evidence shown to us or presented to the board whatsoever on this factor. And we know from common sense, numerous public sources, and the public comment we've been receiving that payers, particularly commercial in Vermont, are extremely strained in their ability to pay for more. Second, the hospital's ability to limit services to meet their budget, consistent with its obligations to provide appropriate care for all patients. That's the second factor. This is something where we could have had an opportunity to work with the hospital to evaluate what could be done. I will note that there is a large PHSO at UVM with tens of millions of dollars dedicated to it and a growing expenditure financially and a large and growing FTE commitment. There's also a longstanding ACO. The goals of these are for population health to make people healthier and not need hospital utilization as much, and so they don't show up as sick. And as a network, UVM has the ability to move patients to appropriate care settings and to improve population health so patients aren't sicker. Over the last 5 years, we've seen Vermont dedicate more and more of its limited healthcare dollars to hospital spend, while other community providers have struggled and not grown at the same rate. And certainly the lion's share of that expenditure has gone to the University of Vermont. To hear in this budget process that more patients need care and that they're sicker calls into question for me whether our policy of continuing to dedicate these sums of money to hospital care or into UVM in particular is working and consistent with our population health goals. I think that UVM has many talented people, many hardworking, committed doctors and executives, and focusing on population health, given the resources dedicated to it, is really, really important. Mr. Davis, that may be you. Thank you. The financial position of the hospital in relation to other hospitals and the healthcare system as a whole is the third factor that the board is called upon to consider. Overall, UVM has a strong financial position compared to what we've seen from other Vermont hospitals and the health system as a whole. Indeed, an insurance company this year had very serious insolvency risks, and numerous other hospitals have under 100 days cash on hand and not nearly the reserves. In fiscal year 2023, the financial statements demonstrate that UVM has $87 million owed to it from other network hospitals, and their long-term debt to capitalization and debt service coverage ratios are both reasonable and not points of concern, and there's significant funded depreciation. So I find that that factor favors enforcement in this context. The fourth factor is the hospital's performance under budgets identified or established under the Vermont statutes for the previous 3 years and for the next projected 3 years. Considering past budget performance shows that there's been a pattern of under-budgeting potential revenue sources and over-budgeting certain expenses, such as GME dollars, which happened in 23, which happened in 24, sole community hospital dollars, free care and bad debt to the tunes of tens of millions of dollars a year, and excluding money owed from other network hospitals. I am not suggesting that there's anything improper in this, merely that it has not been reliable or accurate, and that has influenced this board's budget decisions. Moreover, there was considerable increased revenue from Medicare and Medicaid in 23, and we see fiscal year 24 projected budget being out of compliance potentially again. And perhaps most importantly to me in connection with this factor is we see troubling expense control. Ms. Barraby's presentation showed the UVM expense growth as compared to other state hospitals. It is very large. UVM is dragging up the expense growth in the state, and we need to control expense growth if we're going to have an affordable healthcare system. Fiscal year 23, they were significantly over their budgeted expenses. Lastly, the last factor is any other considerations deemed appropriate by the board. And here I would just flag, I think there are opportunities to control expenses. I think there are opportunities to look at how service lines are delivered. And I think it's important to increase access in this healthcare system. I agree with that. That's why the board in 24 gave a small rate increase, but a very large NPR increase. We saw that decreasing prices allows us to control cost and increase access. This is going to be the rub of our healthcare system over the next 3 to 5 years with hospitals. Our prices are really, really high. And if utilization upticks, we will bankrupt the system and have serious insolvency concerns for insurers and affordability issues for Vermont. This is the problem we will need to tackle. And in this context of fiscal year 23, given the various sources of revenue that weren't in the budget, I support enforcement. I do favor a 2-year enforcement period because I think it does provide an opportunity to collaborate and work with UVM. However, I will note I would have preferred if there was an opportunity to collaborate prior to this coming to the board. Any other board member comments?
Yeah, I will add some commentary, and I appreciate those of my colleagues on the board. This has obviously been a tough few weeks with a lot of information to review and a lot of things to consider. I've been doing this for a few years, as people know, and I'll say that UVM's budget submissions have grown increasingly more difficult to approve and overages increasingly necessary to correct. The evidence that UVM has used to support their claims of low cost and high efficiency to me have not been persuasive. Their expense per adjusted discharge has risen from below the 25th percentile among teaching hospitals to just at or above the 50th percentile in 3 years, 67% growth in 3 years. Their clinical productivity is on the lower end of national benchmarks. And as others have pointed out, their standardized prices are among the highest in the country. And so when I think about what's really most troubling, I think, is that in both fiscal year 23 and fiscal year 24, they requested rates far higher than it turns out that they needed. As Chair Foster has mentioned, in fiscal year 23, they requested 19.9% effective commercial rate increase, claimed it was all necessary. We allowed 14.77, which was very difficult to swallow. I was there for that. That was a very challenging budget cycle. But then, as Chair Foster pointed out, the UVM response was threats of service cuts and financial demise. None of that materialized. Services were not cut. Access to care actually increased, and they wound up exceeding their budget cap and generated a higher operating margin than expected by about $25 million. Even with that our board's downward adjustment to their rate increase. So again, for fiscal year 24, they requested 13.5% increase in commercial rate. We only allowed 3.1. Again, the response tended towards fear-mongering, threats of compromised access, and concerns about financial demise. And yet again, I think it's clear from some of the projections that UVM is running way over budget, despite that reduction that we made in their requested rate increase. The unfortunate consequence for me of the past 2 years is that I no longer find UVM's rate requests credible. Had we approved anywhere close to the rates that UVM requested in 23 and 24, school systems, local insurers, and households would be facing an even greater affordability crisis than they do today. Some of that 23 overage relates to increased utilization. And to be very, very clear, I was happy to see the improvements that UVM has made to increase access to care. That is what UVM should be doing. And not because the board asked them to, as we have heard, but actually because UVM and its leadership team want to do what's best for the people that they serve. As I see it, though, that $80 million revenue overage is the net effect of many drivers. Yes, that's partly due to overutilization or unexpected utilization. But some of that significant overage is related to unbudgeted windfalls, right? There was an additional $30 million in GME. There was almost not $10 million in sole community status. And there was $33 million in budgeted bad debt and free care that did not materialize. A trend that we're seeing in some of the budgets that are submitted of late from UVM. So millions of dollars of unexpected revenue without commensurate cost. Had that revenue been budgeted, the commercial rate ask should have been lower. So given all the revenue windfalls, given UVM's exceedingly high standardized prices, by some accounts the 9th and 10th decile nationally, their NPR projections for 24 that appear to again exceed the budget order, and frankly, the need to give UVM sufficient room in 2025 NPR to accommodate what I consider very laudable increased access efforts. So I will support this current motion. I do approve of the idea, the notion of giving a glide path over 2 years, given the reductions we've already agreed upon from their submitted budget. I think a glide path is prudent here.
Thank you, everyone, for your thoughts. So I guess I could have said this before with Porter, but just to clarify, I support enforcement in general. The purpose behind the hospital budget process and the correction for deviations from the budget orders is to simulate a hospital global budget. And in attempting to do that, we're attempting to balance volume and price against each other to end up in a place where the budget order landed. And because of the fee-for-service payment structure, that's done retroactively. So I would support for all 3 hospitals some sort of enforcement. And an enforcement on price makes sense to me. I've voted for that multiple times during the almost 7 years, 8 years, I can't even remember at this point that I've been on the board. But what I've also learned from those votes is that there is a compounding impact of price reductions, just like there are for price increases. And I think there potentially have been some overcorrections in the past. So that makes the issue for me not the enforcement in general or the reduction in price as the issue. For me, the issue is the number. I don't recall a time when the enforcement has been 100% of the NPR overages. My recollection of the past enforcements on price have been connected to margin overages. Those are the ones that I happen to remember. In this particular case of UVM, they did, and maybe overage is the wrong word when talking about margins, but there's money that was made based on the NPR overage. I think that's an important consideration because to other folks' comments around access, if there is an increase in access and thus an increase in NPR on a service that loses money, but that we all agree improves population health, you would want to consider that. And so I don't feel like the numbers in this specific instance consider the whys sufficiently for my personal perspective. So I'm supportive of enforcing. I'm supportive of the 2 years. I'm not supportive of the number.
Thank you all. Any other board member discussion or comment? It seems
Can I
we
just
have
ask?
I don't know, 2 or 3. Go ahead.
So one thing on that, Robin, I appreciate your comments a lot. One thing I think I don't know all the details of prior enforcements on commercial price, but my understanding, at least, and please correct me if I'm wrong, is that there was one on Copley and one on Northwest, which are both very low-priced hospitals to begin with, and I think potentially could have had deleterious effects on that. Are you familiar with any high-priced hospitals who've had enforcements on commercial rate through the recent past?
So I think both Northwest and Copley are now low price, potentially in part because of the corrective action. I'm not sure that the evidence in front of us at the time supported that they were low price at the time. With that said, we did not have as good data and metrics on relative actual base price that we have today. So that was based on the information that we had in front of us. So I'm not sure that so there's a cause and effect there that I don't know that we've totally unpacked. just to be frank, from those past enforcement actions. But certainly there were two, I think, on Northwest, maybe one or two on Copley, and then also Rutland, although they came forward with a proposal to cut their own rate. But that was in response to an overage and the fact that the board was looking at price reductions as a result.
Yeah, sorry, I've thought about this and I should have noted that it seems at that time there was not the clarity, or at least the metrics as to relative prices, and that I imagine that was a really challenging decision to make. So I didn't want to sort of imply that that was sort of a known entity at the time. But I think now with the knowledge that we have, I think if we, you could retroactively look at what that would do for Copley and Northwest, but I think that the enforcements were pretty small compared to the magnitude of their prices being below average. So it probably contributed, but I don't think an enforcement on UVM of the size that we're talking, knowing their pricing structure, would lead to them being a low priced hospital and have that market disadvantage from that standpoint.
I appreciate your thoughts.
I see that there's been a hand raised. Miss Peak Lee, I'll call on you, and thank you for sending us information the last several days in this important issue and for being here.
Well, thank you all for trying to digest all of the information that you have been receiving, because obviously we're working from our hospital's perspective, but you're looking at all hospitals across the state. So I appreciate the lively discussion. I think you all have been thoughtful in how you're trying to frame this. I do want to make a couple of comments on the area of fixed cost. I am concerned that the concept around fixed may be getting a little misconstrued. When I think of fixed, and then when I think of how we use costs associated with volumes, I just want to bring those two together. You may hear us say that some of our staffing is fixed, particularly in nursing, but it doesn't mean it doesn't vary. It means we have fixed metrics we have to go by. It means we have agreements with our bargaining units for minimal staffing or staffing per certain levels. But that does not mean that it does not change with volume. So I do wanted to bring that in, and I also wanted to state that FY23 was extremely costly to deliver that care. I have provided that information, and we are working to bring down costs of care delivery. That does take time, but I do not disagree that the cost of health care for not just Vermont, but nationally has gone up so much. We as an organization are seeing significant increases in utilization of our own health plan. So we also see that. And within our expenses for that, have seen that exceed what our expected expense line was projected to be. So I certainly can take that view of it, looking internally at what we see, and look outward and understand that that is also impacting small businesses and other members of the community as well. So I do not take that lightly, and certainly do commit, as I have said in my communications, to working on the pathway to a solution. I do appreciate the concept of a multi-year component in any enforcement that is applied, and just want to ensure that there is not any self-manipulation of our budgets. I do not participate in that. I am a very credible CFO and want to assure the board that there is no intent to do that. Additionally, there's certainly information that comes in later
And I have mentioned that we have put that information in adaptive, but perhaps we should do a more formal communication periodically between UVMMC and the board so that we are assured that both the board and UVMC are connected on those things. So I do think there's an opportunity for improved communication. So thank you. I do appreciate your looking at all components of this. I just want to remind everyone that FY22, we did suffer a significant loss, and that did drive the budget request for 23. And I am very proud of all of UVMMC and the network for their work to provide more access for our patients. That was the right thing to do. It continues to be the right thing to do. It did come at greater costs. So I do appreciate you all reviewing all the information that is provided, and do welcome continued interaction with the board. Thank you.
Thank you very much, Ms. Peakley. I will respond just real briefly because I alluded to this, I think, earlier this week. After this process is over, I do think it would be beneficial for the board and UVM to get together to come up with a way to improve communication. I am not suggesting any self-manipulation or anything like that in the budgets. Is more of a concern. I hope I articulated it well. Of we have to rely on it. If it's off, we need to make sure it doesn't impact what we do to commercial ratepayers. And so maybe there's a process where we could have an auditor or something come in, or some sort of monitor to help independently review that kind of information so that we can all have a bit of a better communication in this process. And I think that's going to be so important for Vermont moving forward. So thank you for your comments. Dr. Loeffler.
Thank you, Chair Foster. I just want to make a couple final comments when we're talking about enforcement. So I want to remind the board that in 22, we were still in the pandemic and we lost close to $30 million. We started building the 23 budget in February, and we had no idea at that point were things going to get back to normal and there would be opportunity to schedule a lot of care, or if we'd still have pandemic issues. That's why we built the rate that we did. It turns out the 23, the pandemic was mostly behind Vermont, not completely. And then we had a huge pent-up demand and we delivered a lot of care. There was huge cost to that. Traveler costs were still exceedingly high in 23, and we used many, many travelers, paid overtime, special pay, everything that we had to do to serve all the patients who sought us in 23. We took care of patients who were transferred to us, who were stuck in other small hospitals and needed to come, and more local patients at huge cost. In fact, we lost money on the dollars you're enforcing, but I'm proud we did it because it was the right thing to do for Vermonters. Going forward, we are doing our best to present budgets that are as close as possible. I'll be honest with you. We start building the budgets in February. It's actually amazing to me they can be within 4% of projection because the numbers are huge and small changes make really big differences. I appreciate the complexity the board is dealing with. I'm very focused on trying to manage affordability for Vermonters. Utilization actually does cost money. And the fixed cost, the only way to really reduce our fixed expenses is to reduce services or have layoffs, but there's a variable cost to doing more. We have to hire more people, pay overtime, pay special pay, or bring in travelers. And so that's what we're trying to manage every single day and care for everyone who needs us. Thank you.
Thank you very much, Dr. Loeffler. Any other public comment? Actually, I apologize. I normally call him a healthcare advocate. Was there any comment from the healthcare advocate?
I was trying to decide whether to speak, Mr. Chair. You're
You
calling
still
on
got
me,
time to decide.
You're calling on me, got me to open up my camera. First off, thank you, all five of you and everybody and staff. Really important conversation. I just want to reflect for a minute. All five of you I have heard say that you're supportive of enforcement. Four of you have expressed in support for 100% enforcement with some difference about 1 year or 2 years. So while it sounds like there's been some difference, there's quite a lot of agreement. The healthcare advocate, we have been clear that we think in order for this whole process that we put so much time into, all of us, to mean something, there has to be enforcement. Otherwise, I'm not sure why we're doing it. So I appreciate the amount of agreement that there is. I gotta be honest, I have a hard time imagining how a 26 enforcement. I ask myself the question, what are the chances of a part of this enforcement happening in 26, especially if there's concerns about the actuals for 24? And so I find myself more on the side of doing the enforcement that you're willing to do this year, even if it's not 100%. All of that is process comments, I think. But I'm encouraged by this conversation. I see a lot of agreement amongst the five of you, and my office for that matter, and wonder whether there's a path to finding an agreeable number that the five of you can agree to for this year, recognizing there'll be more bites at this apple next year and every year. Thank you, Mr. Chair.
Thank you. And certainly every hospital budget has some variance, and that's why we have that 1% buffer. And this process allows to correct for when those projections turned out to be off. Because if those projections can be significantly off, it does result in increased rate that in this context, I think the board agrees was unnecessary to impose on Vermonters, which is, I think, part of what we're all saying and thinking. It's not clear to me whether or not this motion will carry, but I think we should take it for a roll call vote and see what happens. And if we need to modify and adjust from there, we'll take it as it comes.
All right, so taking a roll call vote on the motion language that is up on the screen right now, just to be clear on that. I get to test my alphabet again today. Member Holmes, do you vote yes or no?
Yes.
Member Lunge, do you vote yes or no?
No.
Member Merman, do you vote yes or no?
Yes.
Member Walsh, do you vote yes or no?
No.
And Chair Foster, do you vote yes or no?
I vote yes.
I heard 2 against, 3 for, motion carries.
Thank you. Can you put up the next slide, Mark? And why don't we take, it's 12:30, 12:25 anyway. I think we should take we take a 45-minute lunch break.
Just
and we
a
can come back at
reminder, Chair Foster, I've got a hard stop at 1:15 today.
Oh, maybe we won't do that. Why don't we take 5 minutes then? We'll come back at 12:30. You're sorry, Dr. Merman, 1:15 is your hard stop?
Maybe 1:20, but yeah.
Okay, all right, we'll come back at 12:30 then. Michelle, we can go off the record.
Sorry, everyone. Thank you, though.
Okay, we're off the record.
Kristen, just a small typo on that. It's hopefully the hearing's going to resume at 12:30 p.m.
Thank you.
Unless we're coming back after my shift.
Hey, Michelle, are you here?
I am.
Okay, we can go back on the record.
Okay, back on the record.
And given the time, we're going to need to pick up the pace a little bit so we can get the benefit of Dr. Merman's thoughts and votes. Mr. Henksler, could you pull up the slides?
Doing so right now. All right, next up we have motion for Rutland. I won't talk very much, but same idea that for UVM. This was the language verbally put forth in motion at the last deliberative session. And here is a change that is the same concept as what we discussed previously with UVM. If there are any questions about that change, we can address those, but it's the same concept.
Thank you. I'll read the motion and then we will take board member comment and discussion. I move that we find RRMC's performance differed substantially from its fiscal year 23 budget. Move to deny RRMC's application for retroactive adjustment of its fiscal year 23 budget, and move to enforce this deviation by reducing the fiscal year 25 overall change in charge and commercial negotiated rate increases from 2.8% over current approved levels to 1.2% over current approved levels, with no commercial rate increase for any payer exceeding that amount, and with a $2,766,215 reduction to RRMC's fiscal year 26 commercial MPR to be applied to its approved fiscal year 26 commercial rate in this board's fiscal year 26 budget order.
A second.
And I'll open it up to board member comment. We can stay in the same order. Dr. Walsh, if you have anything.
Nothing new. I think the 2-year horizon is more problematic than helpful.
Dr. Merman?
I'm in agreement on preferring to do this all in 1 year as opposed to 2 year, and I really don't want this to be seen as setting a precedent for 2-year enforcement actions in the future. That was not my intention of voting for the last motion. And I also just want to clarify that there was some public comment to this of taking money away, and I don't see this as a clawback. I see this as a correction for a very high commercial rate increase in FY23, and actually just regard to Dr. Leffler's comments in the last motion, I think they probably apply to this, that it must have been remarkably challenging to conceive of an FY23 budget in 22. That was a time with significant unknowns. And so I don't hold blame. I don't hold ill thoughts about trying to do the best budget that people could do in 2022 for FY 2023, but I view this as a corrective action to those high prices from that time, and I think that we need to overall think about how to manage our high prices in certain areas of the Vermont hospital sector. So, given all that, I would prefer this to occur over 1 year. I think the proportion of the enforcement amount is appropriate given the circumstances discussed in the prior deliberative sessions, and will support this motion here.
Member Holmes, any comments?
I do. I want to acknowledge, first of all, the challenges we all face in making a pretty difficult decision. I spent a lot of time reviewing the submissions and the documents related to enforcement for all the hospitals, as I'm sure we all have. For me, Rutland is different than the last hospital we talked about. Unlike UVM, there were no near costless revenue windfalls for Rutland. There was no Medicare rate bump. There was no GME that was unexpected. No over budgeted bad debt free care. In fact, Rutland under budgeted both bad debt free care and custodial care. In other words, they provided more care than they expected that did not free care than they expected that they didn't get reimbursed for. From the information I've seen, they served more Medicare patients than they had higher Medicaid attributed lives than they expected. Again, this likely means they delivered more care whose costs were not fully covered. They had unexpected ED utilization due to unexpected lack of primary care and urgent care in their community beyond their control. EMTALA obviously prevents them from limiting that care, which is one of our considerations. They increased access and accepted patients from Addison County when Porter's orthopedist retired and patients had nowhere to go. Wait times at UVM were still exceedingly long. So Rutland expanded access to accommodate those unexpected patients. And when I look at that extra utilization, their operating margin was still less than budgeted, perhaps related to the payer mix of the patients that they served. Again, unlike UVM, I actually want to acknowledge that the Rutland leadership team in this case self-regulated to some degree, perhaps later than we would have liked. But the median hospital in their fiscal year 25 budgets asked for a 4.6% increase in commercial rate. Our guidance allowed 3.4. Rutland asked for only 2.8. In a sense, self-regulating, doing that self-correction that we would like to see. So if we don't acknowledge their effort at that self-regulation, we run the risk of having every hospital come in and ask for the guidance cap or even more than the guidance cap whenever they face a potential enforcement action, if we're reducing from where they submitted. So for me, for the reasons that I've outlined, I am a no on this motion, but I will say that if Rutland is ending the year high for 24 and sees continued high revenue growth exceeding NPR in the first quarter, I would encourage them. I would like them to come in and talk about a proactive downward adjustment in rate to stay within their budget. And I would just say, I think hospital-initiated corrective action in real time is likely to go a long way with the board, I think, as we've seen. At least it used to. So that's all I have.
Thank you. Member Lunge?
I don't have anything new, and I agree with Jess's rationale and summary, so I'm also a no.
Thank you. I do see this hospital and situation as distinct from the other enforcement action. There are some important distinctions, but there are some similarities. One is it was a giant fiscal year 23 rate increase. I believe it was over 17%, and it was in fact unnecessary to put that burden on commercial payers, as I see it. And hospital actual revenues for fiscal year 24 are also again projected to be over. One of the other factors we're supposed to consider is the resources of payers to pay the overage. Again, I do not see any evidence in the record suggesting that our payers have an ability to pay this, and I do not think that they do. Different than UVM, I do not think they had the same ability to move care as well as UVM could have. That's different. The financial position of the hospital, though, they are well resourced. They have significant days cash on hand, over 200, and they have long-term debt to capitalization, debt service coverage ratios that seem to be not concerning, and they have significant funded depreciation. So I think that factor does support enforcement. One other distinction from UVM that I think is important, though, is that they have done a pretty good job of controlling their expenses. UVM's expense growth is considerably higher than Rutland's, and Rutland's leadership has taken significant steps to do that, and that really should be acknowledged. And I recognize that. So I think that there's less ability as opposed to UVM. There's good financial health, and overall balancing all of those factors and the burden on commercial payers, I think that it should be a 50% enforcement as opposed to the full enforcement for UVM. So I consider those factors. I think members Holmes and Lunge made good points. I just weigh them and come out to a different position, although I respectfully completely understand them. And they also impact my view that it should be 2 years and only a 50% enforcement. As before, I'm going to open it up to public comment, as we seem to be, we have a couple different positions. And I wanted to thank the Rutland team for its information it's been providing the board nearly daily. It's been reviewed and it is helpful. Ms. Fox?
Good afternoon. Thank you, Chair Foster and members of the Green Mountain Care Board. I'm Judy Fox, the President and CEO of Rutland Regional Medical Center. I want to start by thanking you for allowing me to speak on behalf of Rutland. And I'd like to recognize the board's position and the complexity in reviewing the data that has been submitted. It is certainly not an easy process for any of us. The strength of our hospital is vital to the health and well-being of our region. As CEO, it's my responsibility to ensure that we provide consistent, high-quality care for our patients, care they need, and frankly, care in which they deserve. Today, I must express my deep concern. The motions made by this board will, without a doubt, undermine Rutland's ability to meet the needs of our community. The reductions in our hospital budget do not achieve affordability goals we collectively share. Instead, they threaten access to care and place the health of our patients at significant risk. Our 2025 budget reflects investments in critical services, specifically diagnostic imaging, surgery, infusion therapies, and specialty care. Let me be clear, these investments are not luxuries. They are, in fact, lifelines our patients depend on. We've thoughtfully and carefully expanded these services to reduce the very wait times this board has mandated that we monitor. And the results? Well, the results are clear. Reduced delays, which we've reported to you, faster diagnosis, quicker treatments, all while providing high-quality care. These improvements directly benefit our patients' lives and align with the goals of this board. Yet despite these efforts, Rutland's net patient service revenue has been arbitrarily reduced by over $6 million. This is the impact of your decision. Rutland will be forced to reduce care that our patients desperately need. And I want to be very clear, this is not an empty threat. This is a reality. We're talking about longer wait times for potentially 1,200 MRI scans, 375 surgeries, and over 400 infusion treatments. These aren't just numbers. They're people who will now face unnecessary delays in receiving the care they so desperately need. The demand for Rutland Regional Services continues to grow, not only from Rutland County, but from across the state. Patients are traveling to us for high quality, timely care. And yet this board is restricting our ability to serve these patients. If the restrictions stand, there is one major result that is not being discussed by the Green Mountain Care Board. Patients will seek care outside of Vermont, taking their care and their healthcare dollars elsewhere. But those who can't afford to travel, our most vulnerable among us, will be left without the care they need, without the timely MRI to detect their life-threatening condition, or without the surgery they need to return to their life and their work. Now, let me be clear. We're not asking for more than what is necessary. Our 2025 budget included a $4 million expense cut. We have used reserve funds to fund our capital needs, all while keeping our commercial rate below the 3.4% guidance. Since the pandemic, we've cut over $10 million in operating costs and reduced the cost of care by over $1,100 a discharge, despite rising inflation. Our new management team has done its part. We have worked hard. The work has been performed with the sole focus of patients and employees in our community. But the reality is humbling. Rural hospitals like Rutland Regional face unique challenges: an aging population, mental health crisis, addiction, housing shortages, recruitment difficulties, access to childcare, and of course, access to healthcare. These are the daily realities we confront. Rutland Regional is more than a hospital. We are a safety net for our community, but that safety net comes at great cost and requires thoughtful and diligent support. To truly reduce costs and improve access, we need a comprehensive approach. We need more skilled nursing beds, a functional ambulance system, solutions to homelessness, and transitional housing for those who shouldn't be in the hospital, but just have no place else to go. This is the hard work of healthcare, and this burden cannot and must not fall on hospitals alone. We are committed to this work. We are committed to our community, but the motion made by the board this week, these motions, they jeopardize our ability to meet these critical commitments. We need partners who understand that cutting budgets does not cut the need for healthcare. Rutland Regional is ready to work with you to find solutions that ensure access to care for our patients. But the board's current actions are not collaborative towards Rutland Regional and do not show that we believe in partnership. Thanks for your time.
Thank you. Other public comment? I'll just respond briefly from my own viewpoint, which is the situation can be very different if it is a low-priced hospital. We understand that anytime the money isn't available to the degree that people want, it's difficult. I think that given where the prices are with Rutland, they're not so low that there isn't opportunity to decrease prices and still provide care. In fact, to some degree, it could be the opposite in that it allows more room to provide care to the community. In terms of cooperation and collaboration, we would have preferred if this was brought to the board's attention mid-year so that we could have addressed it. Your points are well taken, but I disagree that this is not collaboration. We have to think about the payers as well, and we do want to work with you. So thank you for your comments. Any other public comment? Keeping an eye on the time, I think I'm going to call for a roll call vote and see where we go.
All right, same as before, we're discussing the motion that's currently up on the deck before the board. Member Holmes, do you vote yes or no?
No.
Member Lunge, do you vote yes or no?
No.
Member Merman, do you vote yes or no?
Yes.
Member Walsh, do you vote yes or no?
Yes.
Chair Foster, do you vote yes or no?
Yes.
3-4, 2 against, motion carries.
I think we had a couple other outstanding hospital budgets as well.
We have a brief item to which I do not anticipate taking much time, which is a final vote on the FY25 standard budget conditions. I say that I don't anticipate this taking much time because since these were presented on the 11th, there have been no changes to them. So I'm just going to briefly click through the slides, but these are the same conditions that the board reviewed on the 11th before the motion was picked up and tabled. And what I have before you is the motion that was made on September 11th.
Thank you. I move to approve the standard budget conditions as presented to the board on September 11th, 2024 to be included as the default conditions for the fiscal year 25 hospital budget orders, subject to any changes to the budget conditions or additional conditions approved by the board for any specific hospitals.
I'll second.
Any board member discussion? Any additional public comment on the standard conditions? All in favor, say aye.
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 Aye. The motion carries.
Next up, we have a few remaining fiscal year 25 budget orders. And I'm just give me a minute here so I can pull up. There we go. So this is the motion as made for Copley's FY25 budget, which is the motion that was made on the 11th. I've highlighted in blue the item that was changed from prior motion to the motion made on the 11th that's currently before the board. So what's currently before the board is a 6% NPR and a 3.4% overall change in charge and commercial negotiated rate increase.
You need somebody to make this motion again?
I think so. I think so, Jess.
I think I did it before, so I can do it. I apologize for the long pause. I'll move we approve Copley's budget with modifications as follows, with fiscal year 25 NPR approved at a growth rate of not more than 6% over its fiscal year 24 approved budget, reduced from 11.8% and commensurate reduction in operating expenses, with fiscal year 25 overall change in charge and commercial negotiated rate increases approved at no more than 3.4% over current approved levels, reduced from 10.5%, and no commercial rate increase for any payer exceeding that amount, and subject to all other standard budget conditions as approved by this board.
Board member discussion?
Was there a second?
Oh, I'll second.
Sorry, board member discussion?
I can go ahead first. I think I had requested this, and I think I went over my thoughts on that last time, but also, in looking at Copley's rates, they are definitely one of the lower priced hospitals, but we have provided significant rate increases over the last few years, which I think have helped move them up in terms of their commercial rates. So I just wanted to add that.
I can add some commentary here. I would support the 3.4% price cap here. Copley requested a rate increase of 10.5. That's after a 12% rate increase and a 15% rate increase in the past 2 years. Yes, Copley has been low priced. The 2022 data from RAND predates those very large price increases. But even in that RAND 2022, I think Copley was about above the national median on outpatient, which is a big driver of their revenue. A more recent analysis that we've seen using the 2023 data, that's that repricing data, uses Vermont data from 2023, shows that Copley has been catching up to its Vermont peers, particularly on outpatient price. And that's again before the 15% rate increase in 2024. Also, Copley appears to be running over budget for 2024, so it's requesting such a high rate increase when they are projecting to be over budget for 24 is worrisome. They just opened a new ortho building that should help increase patient throughput and give opportunity for revenue. And I think ultimately I fall back on our guidance, which was very clear. If a hospital submits more than their 3.4% rate increase, that was inflation plus 1%, that was the guidance, the hospital must demonstrate that it's maximizing productivity. In fact, none of the hospitals were able to really do that. Most had clinical productivity well below the national median, including Copley. So given that they're already projected to be over budget for 24, I'd like to see a little settling in with these recent very, very large rate increases, including just a few months ago, a mid-year rate increase. See where that all starts to shake out before giving any more rate increases above guidance. So I support this motion.
I support this motion as well. Nothing additional to what members Lunge and Holmes have said.
I've looked at the RAND pricing, the Burns pricing. I think last year I calculated for Copley, wouldn't say it's quite back of the napkin. It was an Excel spreadsheet that for them to reach mean outpatient Vermont prices, they would essentially need 3 times the average commercial rate increase per year for 5 years or something like that. So I still think their prices are fairly low. That said, I think given that they're over their commercial NPR now and or over their current FY24 projected is over their budget, and they have low prices, and they have a new building, which should improve their productivity, I'm worried that their NPR could exceed the 6% quite easily. And I would offer a friendly amendment to move up their NPR growth rate to a higher number, say 9%. Because I think that I still feel pretty strongly that allowing low-cost hospitals to grow their market share is overall beneficial to Vermonters, even if the total NPR grows at a rate that is higher than I really want. So a friendly amendment to adjust the first item to a growth rate of not more than 9% over its FY24 approved budget, reduced from 11.8.
I just need a minute to take a look at the numbers in the context of the NPRs. And I appreciate your friendliness, Dave, but I think what makes it friendly or not is whether Jess and I would agree to accept it. So I need a moment before I can agree or disagree to accept it. I mean, the other way to handle it procedurally, I think, would be vote on this. If it goes down, consider your motion next. I defer to Mark and Owen in terms of how they prefer to proceed, but I'm going to try and multitask with a spreadsheet right now.
I think the best course of action on this would be to hear, at least have a discussion on the suggestion by Dr. Merman, and then we can take it from there. Is there any board member, and obviously member Holmes and Lunge have the motion on the floor. Any other board members have thoughts on either the motion on the floor or Dr. Merman's suggestion?
Yeah, well, I find members Lunge and Holmes, their arguments persuasive. My one hesitancy about this motion was the low NPR. I find member Merman's argument persuasive. I would support the increase NPR to 9.
Well,
I guess
member
my question to Dave is would be, with the reduction in the commercial rate to 3.4 down from 10.5, do they have the room in increased utilization to support that NPR?
I think this gets into the complex question of whether or not they budget their expenses to the NPR of 9, or if that gives them some more running room with their sort of current fixed expenses that they have, especially with their new outpatient ortho facility. So I would actually ask Elena to weigh in on that. I don't know if you can do that calculation that quickly, though.
I'm doing some math. Let's see.
Ms. Fairby, why don't you take a moment and
Okay. Can I just read the math to you? And then, so I think I have the 9%. So if you have NPR at 9% instead of 6%, yeah, let me just take a few minutes and I'll calculate both of those questions. I can do that in a couple minutes.
I would say in concept, it's similar to what was passed last year for UVM, which was a higher NPR with a lower price growth in order to encourage or support really utilization growth. And specifically because they're lower cost, I think it makes sense to try to support utilization growth there, assuming they're not generating utilization out of thin air, but it's coming from somewhere else.
Actually, I have it. Okay, so the reduction from their requested commercial price, so moving from 10.5 to 6.4 is about $4 million. Yes. Or sorry, to 3.4, the revised recommendation, not 6.4. From 10.5% to 3.4%, it's around $4 million. When you go from 6 to 9%, that's only additional 827,000. So, but the 9% would be equivalent to an increase in NPR of 2.5. So it wouldn't offset that 4 million. So the rate reduction is quite a bit more than the NPR increase.
I'm just going to take a second and make a couple comments of things that I've been thinking about on this change in the motion from the original one and the comments that have been made so far, just to provide it in case it's helpful. I think Member Holmes and Lunge are right. There have been very large increases of late for Copley. That is certainly true. That was certainly intentional. I am struggling with the projected overage currently in connection with, the higher original motion. However, at the same time, this is a hospital that has shown a lot of interest and support for transformation and is interested in transformation and is willing to take significant steps in that regard. The days cash on hand does remain quite low, and the operating expenses have been lowered for fiscal year 25 budget pretty significantly. So I'm going to read off from the presentation. In 2022, the state average was 13.7% increase in operating expenses. Copley was 8. In 23, it was 6.4. Copley was 4. In 24, Copley is quite a bit over at 11.9, and the state average was 7.4. And budgeted for 25, state average is 5.1. Copley is 3.9. So Copley has taken some significant effort to reduce that operating expense from the 24 number. And those are just some of the things that I've been observing and thinking about with this, to the extent it is helpful to the other members.
Yeah, so I think I can support Dave's suggestion of increasing the NPR. When I look at and I'm going to try and do my math using, so here we go. Buckle up. So I think the 9% NPR recommendation ends up being about a 5% growth over fiscal year 24 projected, which leaves quite a bit of room for volume. I think given that the value of the price increase, even at 3.4%, or I should say, given the value of the price increase at 3.4%, which I think is about 2 million. So I think that is a pretty good balance between price and utilization. I could, 5% growth over projected is still significant, but I could certainly move up if others are comfortable with that.
I'm going to open it up to public comment. Sometimes that's helpful. So if there's public comment, please raise your hand. And I appreciate the public comment and the hospital input we've received the last couple of days and previously. All right, any other board member discussion? And I think members Lunge and Holmes, you'll have to decide if you would like to take the friendly amendment.
Why don't I propose taking the friendly amendment and we'll see if Jess agrees. And if she disagrees, then I think we vote on the motion as is and see where that leads.
I can agree with the friendly amendment.
So then I can restate the motion, which is to approve Copley's budget with modifications with an FY25 NPR approved at a growth rate of not more than 9% over its fiscal year 24 approved budget, reduced from 11.8%, and a commensurate reduction in operating expenses. A fiscal year 25 overall change in charge and commercial negotiated rate increases approved at no more than 3.4% over current approved levels, reduced from 10.5%, and with no commercial rate increase for any payer exceeding that amount, and subject to all other standard budget conditions as approved by this board.
Second.
And I think we're good. I don't think it needs to be re-second. That was just a restatement, but thank you, Tom.
All those in favor of the motion say aye.
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 Aye. The motion carries.
We are moving along to Mount Escutney. I'm going to note the two colors here. So I made changes on the 11th to Mount Escutney's slide to indicate again that the initial request had been 4.3 and what the board was at the time considering was a 3.2. When the motion was taken up, it was taken up with an increase in NPR to the benchmark. So the language before you here is the language as was proposed on the 11th, with a 3.5% NPR reduced from the initial request of 4.3.
Thank you. I will read the motion. Move to approve Mount Escutney's budget with modifications as follows. The fiscal year 25 NPR approved at a growth rate of not more than 3.5% over its fiscal year 24 approved budget, reduced from 4.3%, and a commensurate reduction in operating expenses with fiscal year 25 overall change in charge and commercial negotiated rate increases approved at no more than 2.2% over current approved levels, with no commercial rate increase for any payer exceeding that amount, and subject to all other standard budget conditions as approved by this board.
Second.
Board member discussion? I see a hand raised on Ms. Pitts. I'll call on you for public comment.
Thank you, Chair Foster. Can you hear me?
Yes, ma'am.
Okay, thank you. I appreciate the increase to the 3.5 over the 3.2. And please bear with me. I'm new to this Green Mountain Care Board and I've come in very late into the budget process itself. I just started on August 1st. So if I'm out of order, please let me know. But I just want to make one last plea for the 4.3%. The reasoning is that is composed of two pieces. One is price increase, charge increase, which is 3.5%. And that is a factor on 0.2. That 3.5 will net, according to our calculations, the 2.2%. So changing to the 4.3 will have no bearing on 0.2. The remainder of the increase is really composed of some, what I feel are modest volume and payer mix increases. And this will help cover the certificate of need project that was just recently approved by your board. So thank you very much. For us to install a new medical record, we will be switching over to Epic. And Dartmouth is actually picking up a good portion of that bill. So I respectfully request you to reconsider and keep us at the 4.3 that we asked for. Thank you.
Thank you, Ms. Pitts. And well done. If you're not familiar with the board process, you nailed it. I'll open it back up to board members for discussion in the event there's any response or questions for Ms. Pitts. Okay, I did move the rate up to the guidance level. That's the change that's represented. And the motion's been seconded. So I will ask for a vote. All those in favor say aye.
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 Aye, and the motion carries.
Next, we have Porter. The change for Porter that's represented in NPR is an increase that was proposed by the board and taken up as a motion on the 11th. It's an increase to NPR to 4.2, which is the request that Porter made. I believe this makes this a motion to approve the budget as submitted, as the NPR request from Porter was 4.2 and the commercial request was 2.5.
I think I'd made this change. I forget, but I will make the motion either way. I move to approve Porter Medical Center's budget as follows, with fiscal year 25 NPR approved at a growth rate of not more than 4.2% over its fiscal year 24 approved budget, with fiscal year 25 overall change in charge and commercial negotiated rate increases approved at no more than 2.5% over current approved levels, with no commercial rate increase for any payer exceeding that amount, and subject to all their standard budget conditions as approved by this board.
I'll second.
Board member discussion?
I must admit, I've been knee deep in enforcement. Could you remind me why we moved up the NPR from the guidance to the submitted?
I think one of the rationales was for the opportunity we constrained the network's NPR and to allow for an opportunity to move more of the care in the network down to Porter. Any other board member questions or comments? Mark, why don't we take a roll call vote?
The motion before the board is the motion that's up on the deck right now. I will start with Member Holmes. Do you vote yes or no?
Yes.
Member Lunge, do you vote yes or no?
Yes.
Member Merman, do you vote yes or no?
I must admit, I don't know if I've made up my mind on this one, so I guess, does that mean I abstain? I will abstain for now. See where this goes.
Member Walsh?
No.
And Chair Foster?
Yes.
I heard 3 yeses, 1 no, and 1 abstention. The motion carries. We now move to NMC. This was the item in blue is the item that was adjusted. On the 11th, there was a suggested motion to increase the NPR from 6 to 6.8. So you have a 6.8 in NPR and a 3.4 in commercial, reduced from the request of 6.4.
I will make this motion. I move to approve NMC's budget with modifications as follows. With fiscal year 25 NPR approved at a growth rate of not more than 6.8% over its fiscal year 24 approved budget. With fiscal year 25 overall change in charge of commercial negotiated rate increases approved at no more than 3.4% over current approved levels, reduced from 6.4%, with no commercial rate increase for any payer exceeding that amount and subject to all other standard budget conditions as approved by this board.
Second.
Board member discussion?
I'll jump in real quick. I'm going to try to advocate again for Northwest to get a higher commercial price. We just approved 2.2% for Mount which in real dollars is actually more than 3.4% for Northwest if the RAND pricing is representative of their actual pricing. So I think they are the lowest priced hospital in the state, and far lower. I mean, Copley's low, but they're lower than Copley and far lower than UVM, which is the closest geographic hospital. So I think and they have, a significant potential to increase their market share of Franklin County because a lot of Franklin County seeks care elsewhere. So I think ensuring that they have the commercial price to support the services that they can provide, I think, is important. So I would still advocate for a price increase of at least 5% over their current approved levels. I don't know if people would be willing to entertain a friendly motion for 5%, but I could make a friendly motion for line 2 with FY25 overall change in charge and commercial negotiated rate increases approved at no more than 5% over current approved levels, reduced from 6.4%.
Other board member discussion? I made this motion to increase the NPR for a couple of the reasons that Dr. Merman mentioned, and that I think Mr. Wright had flagged in his public comment and in their budget presentation, which was really important that they had really good expense control, much better than many other hospitals in the state of Vermont. And I think that should be also recognized, which is a reason why I think a significantly above guidance NPR is appropriate here so that they can continue to grow their business as they are quite affordable relative to other Vermont hospitals, as Dr. Merman mentioned. Other board member comments? I'll take public comment. Mr. Wright.
Thank you, Chair Foster, and thank you, Board Member Merman, for your friendly amendment offer. I would just say when we put the budget together, the growth that we put that you're allowing, which we greatly appreciate, is added volume, but it's also on the charge side. So it is hard for us to get there. We are absolutely hoping to capture all the volume. We don't need to add capital infrastructure to capture that market share, and all the things that you said were right. I don't know, 6.4 seems different. I thought we submitted 7.0 as our submission, but whatever you have there, I think is fine for the moment. But I would just ask and plead for your support. The budget that we put together is predicated on both sides for us to be able to achieve that.
Other board member discussion? I'll ask Member Holmes if she's open to taking the friendly amendment.
I am open to taking the friendly amendment for discussion, but I will probably not vote for it. Because to me, the 3.4 cap was very clear in the guidance, and hospitals had to show that they had maximizing productivity to get over that 3.4% cap. And Northwestern has opportunity to improve clinical productivity before going to rate. I recognize that their prices are lower, and I can appreciate that, but I think we were pretty clear in the guidance on that front. Their days cash on hand are also quite high. And so I think there is opportunity for them to work on clinical productivity before going to increased rate.
Their board members' thoughts?
I'm uncomfortable with the price increase. I'd be more comfortable with an NPR increase.
Member Lunge, do you have any additional thoughts?
I don't really have anything to add. I think I'm more comfortable with the motion as it currently stands and not with the price increase.
Okay, Mr. Hengsler, I think a roll call vote would be appropriate on the motion on the floor.
Motion on the floor is the motion that's up on the deck right now for NMC. We'll start with Member Holmes. Are you a yes or no?
Yes.
Member Lunge, are you a yes or no?
Yes.
Member Merman, are you a yes or no?
No.
Member Walsh, are you a yes or no?
Yes.
And Chair Foster, are you a yes or no?
I'm a yes.
I hear 4 yeses, 1 no. Motion carries.
Next motion.
That concludes FY25 hospital budget motions. Motion still on the floor is that for Porter FY23 application for adjustment and enforcement.
Could you put that one back up if you have it handy, Mark?
Yep, just getting to it. Here's the language as proposed today and taken out.
I'll just make 2 notes. The motion is on the floor, and my interpretation of the earlier deliberation was 2 members supported it. Member Lunge believed enforcement might be appropriate, but would like more time to think about the right approach to determining what the enforcement level would be. And I believe members Walsh and Merman also supported enforcement. And I believe member Walsh had used the 67% figure of the fixed costs cited in the testimony. So I think that summarizes where we were. And I will open it back up to see if there's any additional comments from the board members.
So I guess I'll just chime in. I think, kind of given where we are in this process, even with my strong feeling that we should enforce, I can vote for this motion.
Any other board member comment on this motion? Dr. Merman, are you still with us? So I will just note for the record that Dr. Merman had to get to, I believe, the emergency department for work, and he had a hard stop that we've gone over. And so I think he has now stepped out. He wanted to vote on NMC, and I believe he stepped out, although his views on this motion were shared earlier. Having heard member Lunge's views on this at the moment, I think we can go to a roll call vote.
Member Holmes, we'll back up. The motion before the board is the motion for Porter Medical that's on the deck currently. Member Holmes, are you a yes or no?
Yes.
Member Lunge, are you a yes or no?
Yes.
Again, noting for the record that member Merman is not present. Member Walsh, are you a yes or no?
No.
And Chair Foster, are you a yes or no?
Yes.
Motion carries.
Mr. Hengsler, I don't have the agenda in front of me, but I believe that is all of the business we needed to get to today.
Yep, that was it.
Okay. I will thank everyone again, seeing there's no more business for the board in this hearing. A tremendously difficult set of decisions, recognizing that there are not many good answers right now in Vermont's healthcare system. And we appreciate the hospital's understanding and respect, although at times strong disagreement, which I think is actually quite valuable to share. It's important that we understand the perspective. We've tried to consider it and make the decisions that we think are best for the state of Vermont, and balancing all the difficult complexities we have. So many thanks to VAWS in each and every hospital and hospital leadership and provider that participated in this process and made our decisions better. And also to the significant public comment that we received throughout this process. And I would be remiss if I did not extend incredible gratitude and thanks to the board members. There's a tremendous amount of work done by the board members to get this, their thinking together, their questions and their votes. And more importantly is the staff and the hours that Ms. Barabee and Mr. Hengsler and their teams have put in. I won't go through one by one, but we've had an opportunity to hear from them. I'll just note the hours they worked were tremendous, much like on the hospital side. There was times when I saw them working at 4 in the morning, 11 at night, midnight for the last couple months. So many thank you to all of you, and we appreciate it. And I will move to adjourn.
Second.
All in favor, say aye.
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 Aye. And Michelle, thank you for your work, and we are adjourned.
You're welcome. And we are off the record.